Hello my dear students, welcome to our small group presentation today. Pain. I am Dr. Dua Wasim, Assistant Professor of Rheumatology and Rehabilitation. I prepared this presentation with my colleague Dr. Marwa Abul Hawa. Our references are the PETS Guide to Physical Examination and History Taking, First Aid for the USMLE Step 1, 2016. Before we proceed to different causes of shoulder pain, we should learn ILOs. Our ILOs here is to recognize the different anatomical structures of shoulder joint, identify the different causes of shoulder pain, and learn different characteristics and types of shoulder pain. The first, we should know the proper bony and soft tissue structures of shoulder joints and also the different causes of joint stability. The shoulder joints, as we know, there is an articulation between the head of the humerus and the glenoid cavity of the scapula. This is a shallow joint and the stability is deficient. The dislocation and subluxation of shoulder joint is very common due to the broad range of motion of this joint. This is the anterior shoulder. This is the articulation of the head of the humerus with the glenoid cavity. The bony landmarks we should know here is the groinoid process and the acromion. The clavicle and the articulation with the lateral end of the clavicle with the acromion, the acromioclavicular joints, the very important joints in the differential diagnosis of shoulder pain. Also, the very important landmarks is the greater tubercle and the lesser tubercle of the humerus, and in between these two tubercles, the bicipital groove where the bicipital tendons passes. The posterior shoulder, we should identify the scapular spine, the supraspinous fossa and the infraspinous fossa, where the supraspinatus and infraspinatus muscles inserted. Also the acromion, the posterior border of the acromion is very important, the surgical neck of the humerus, and the articulation between the head of the humerus and the glenoid cavity. This is the posterior view of the shoulder joint. The fibrocartilaginous rim surrounding the glenoid cavity called the glenoid labrum, and this is a very important structure that deepens the cavity of the glenoid fossa, and hence aids in the stability of the shoulder joint. This is the site of the labrum around the of the glenoid cavity. The bony structure ends, but the soft tissue structures are very important in the stability of the joint. The soft tissues around the shoulder joint are the muscles and the ligaments. About the ligaments, the most important three ligaments in the structures of the shoulder joint or support the shoulder joint are the coracoacromial ligaments between the coracoid process and the acromion, the acromioclavicular between the acromion and the lateral end of the clavicle, and the coronoid or conoid ligament between the coronoid and the clavicle. This is the three important ligaments that support the shoulder joint. Also, there are numerous muscles supporting the joints, the supraspinatus, infraspinatus, subscapularis, biceps. All these muscles are inserted in the humeral head in different spaces, and also share in the support of the glenoid cavity or the glenohumeral joint or the shoulder joint. What about the bursa? These bursa, the bursa are the synovial membrane-covered spaces that presents at the site of friction between the tendons and the bones and prevents the tendons from tear or rupture by the motion of the joint. These bursa are lined with synovial membrane, and sometimes it is inflamed, and the synovial fluid inside are increased in the amount and also causes a severe pain in the shoulder region. The most important bursa in the shoulder are the subscapularis bursa between the tendon of subscapularis and the conoid process, and the subacromial bursa. Sometimes we call it subacromial subdeltoid bursa because it lies under the deltoid muscle. These subacromial bursa prevent the tendon of subscapularis supraspinatus tendon from friction with the acromion. This is a very important bursa and the more liable to be inflamed. What about the stability of shoulder joint? The stability of shoulder joint consists of two restraints, static and dynamic strains. Static strains consists of the glenohumeral ligaments, the three important ligaments, as we said before, and the glenoid labrum, the fibrocartilaginous rim around the glenoid cavity, and the negative intra-articular pressure that adapts the head of the humerus against the glenoid cavity. These are the three main static restraints that considered in the stability of the shoulder joint. What about the dynamic restraints? The dynamic restraint, dynamic means motion, so the muscles are responsible for this type of restraints. Most important muscles responding for these dynamic restraints are the rotator cuff muscles. Rotator cuff means three muscles. There are supraspinatus, infraspinatus, supraspinatus, infraspinatus, and teres minor. These are the three important rotator cuff muscles. The rotator interval. The rotator interval consists of four layers involving the capsule of the shoulder joints, the coracohumeral ligaments, and the supraspinatus and infraspinatus. Also, the long head of biceps may be interfere with this rotator cuff interval. The long head of biceps and the periscapular muscles, the muscles around the shoulder joint, subscapularis and teres minor, also share in these dynamic restraints. I put to you a very wonderful video showing the proper bony and soft tissue structures 3D in this YouTube link. I hope you to watch this video, and then we proceed to the shoulder examination. Before I enumerate the shoulder joint pain and the differential diagnosis of this pain. The shoulder examination, as we said before, in every joint, we firstly inspect the joint, then palpate the joint, and then proceed to the motion, and then the special tests if we would like to proceed to the special tests. Firstly, the inspection of the joint. Inspection of the joint should be done anteriorly, from the lateral side, and posteriorly. Every side from these three sides should be considered to confirm the diagnosis of shoulder pain. So you should look for the bony contour, the alignment of the bones, the acromions, the groinoid, and the alignment of the or the adaptation of the head of the humerus with the glenoid cavity is very, very important. The soft tissue around the joints, the ligaments, the bruising of the tendons, atrophy of the muscles, symmetry symmetry of the right and left shoulders are very important to look for. As regards the palpation of the joint, you should palpate the bones, the bony structures of the joints, the acromion, acromioclavicular joints, the clavicle, the sternoclavicular joints, subacromial space, spine of the scapula. See the alignments, there's the tenderness or swelling, irregular or irregular swelling. All these should be felt in these bone structures. Soft tissue, you should palpate the deltoid muscle, the trapezius, bicep tendon are very, very important, and the sites of Bursae, as we said before. This is the shoulder joint, and here is the acromioclavicular at the tip of the shoulder joint. Look for the erythema, also of overlying skin swelling, whether it is a fluid or osteophytes due to degenerative process. The glenohumeral joint or the shoulder joint here, we should inspect it for any swelling in this joint, because it is a deep joint. The don't see this swelling if there is minimal or moderate effusion, but it is if there is massive effusion, the swelling will fill the triangle between the lateral end of the clavicle and the medial border of the deltoid and the pectoralis major muscle. This triangular area between the clavicle and the lateral end of the deltoid and pectoralis, this triangular space will be swollen and full with fluid and be tender point here, indicating that there is a massive effusion in the shoulder joint. Also, we look for the erythema of overlying skin if there is inflammation in the joint. Also, don't forget to inspect the supraclavicular space for any swelling or tenderness. The muscular bulk here, especially the deltoid muscle, should be bulky, and the comparison between both shoulders is very important to see the difference between the bulk of muscles in both sides. Inspection at rest from behind, we should look for the scapular position. It is the imposed sign comparison between the right and the left shoulders. Look for the contour of the muscles, the deltoid, the supraspinatus and infraspinatus, trapezius on both sides, rhomboids, and also the erythema of the overlying skin or any deformity present in the scapula, like small scapula or underdeveloped elevated scapula. There is a congenital anomalies may be found in the patient. We also should look for. Inspection during motion. A quick screen for the joint and rotator cuff problems. Firstly, you place the hands around behind the neck So you test for abduction, external rotation, and flexion of the glenohumeral joint and supraspinatus, infraspinatus, and teres minor muscles. Take the hands down and round behind the back, testing for the internal rotation, abduction, extension of the glenohumeral joint, and principally the subscapularis muscle. If there is no pain or difficulty in this motion, this is a normal joint. If any pain or difficulty while we performing these actions, so do the painful arc motion. What about the painful arc? Ask your patient to raise the arm slowly through the 180 degree towards the ceiling, and then slowly to lower it again. And notice that the initial 90 degree representing the glenohumeral abduction motion, the shoulder joint itself, the next 70 being principally scapular rotation, and the last 20 being further glenohumeral movement. So don't forget these degrees. This is important, very, very important to perform, to consider the cause of shoulder pain here in the patient. During the latter half of this composite movement, the sternoclavicular and acromioclavicular joints are also moving, and many people also tend to rotate their arms. If the middle arc is painful, the pain within the central 30 degree as the greater tuberosity of the humerus rises relative to the acromion and can squeeze the intervening structures like supraspinatus tendon and the bursa. As the arm is further elevated, the greater tuberosity drops relative to the acromion and relieve the pressure. This test is very, very characteristic for the supraspinatus lesion or bursitis, subacromion bursitis. But if the painful arc is superior, if it's superior painful arc, the pain in the top 20 to 30 degree of the arc, this is a maximal stress on the acromioclavicular joint, so consider acromioclavicular joint problem. Proceeding to the palpation, you should stand behind the patient while sitting and look for the tenderness at the joint line, swelling, and consider if this swelling is a soft swelling or a bony swelling to know the cause of this swelling, and palpate the temperature of the skin by the dorsum of your hand. Then proceeding to the movements, the flexion motion is raising the arm in the lateral plane from 0 to 180 degrees, extension, return to the anatomical position, and hyperextension from 0 to 45 degrees back through the lateral plane, and abduction, the arm moving in the frontal plane away from the body with 0 to 180 degrees of motion. Adduction, this is the arm moving back to the midline with 0 to 180 degrees of motion. External rotation occurs in the transverse plane and 90 degrees out from the neutral, and the internal rotation occurs in the transverse plane. This can go to 90 degrees into the body, and horizontal adduction occurs in the transverse plane. Neutral is 90 degrees of shoulder abduction, so the horizontal abduction is 120 degrees and adduction is 30 degrees. This slide shows the action or the motion of the scapula during the shoulder motion. Should be considered also the downward rotation while doing the adduction of the joint. The scapula will be downward rotated, and while elevating the shoulder, the scapula will be upward rotated. while shrugging the shoulder like this, leading to elevation of the scapula, and when depressing the shoulder, the scapula also will be depressed. While adduction, the action of rhomboids here, the adduction or protraction of both scapula together, and adduction and reduced lateral tilt or retraction will be the action of serratus muscle like this. The action of the scapula is very important also while examining the shoulder range of motion. The elevation of the scapula corresponding to the upper trapezius levator scapula. Depression of the scapula considered the lower trapezius. Retraction of the scapula, rhomboids and middle trapezius, protraction of the scapula corresponding to the serratus anterior, and the upward rotation of the scapula, the upper and middle trapezius are the responsible muscle. The downward rotation of the scapula, the rhomboids are the corresponding muscles. Don't forget to do the resisted active abduction. This is to diagnose the supraspinatus tendonitis, and resisted active internal rotation to diagnose subscapularis tendonitis. Resisted active external rotation to diagnose the infraspinatus teres minor, and resisted active supination to detect the bicipital tendonitis. This is a wonderful link for the shoulder examination. You should watch this video to show the mechanics and the proper examination of the shoulder joint to aid you or to help you for the study the shoulder pain causes, different causes of the shoulder pain. We proceed to the causes of shoulder pain here. We divided it into non-arthritis shoulder pain and arthritis shoulder pain. Non-arthritis caused by trauma or degenerative process or tumors like subacromial impingement, subcoracoid impingement, rotator cuff tear, subacromial subcoracoid bursitis, adhesive capsulitis, bicipital tendonitis, biceps tendon rupture, acromioclavicular injury, shoulder instability, and maybe referred pain from other side. But the arthritic causes may be inflammatory arthritis like rheumatoid, SLE, GIA, juvenile idiopathic arthritis, gouty, or crystal-induced arthropathy, post-traumatic arthritis, osteoarthritis or degenerative process, infection septic arthritis, neuropathic arthritis, osteonecrosis, or capsulorrhaphy, or post-operative arthroscopic arthropathy. All these are arthritic causes of shoulder pain. The shoulder pain may be articular inside the shoulder joint itself, or extra-articular around from the soft tissue structures around the joint, and we should differentiate between them. The articular causes, the cause inside the shoulder itself, the swelling and tenderness involves the entire joint and may be associated with crepitus or instability, deformity, and the very important item is the limitation of both active and passive range of motion. But the extra-articular structures corresponding for shoulder pain point or focal tenderness in the region adjacent to the articular structure, limitation of active range of motion, not the active and passive. If the active and passive, this is articular, but the limitation of active range of motion only is extra-articular cause of shoulder pain, and rarely causes swelling, instability, and joint deformity. We considered the history. The age is a very important item in the history taking while examining the patient with shoulder pain. We ask him about his age. The age is very important. Aids you or help you to know the proper cause of shoulder pain. Adolescent and young adults, the most common cause of shoulder pain or sport injury, like the acromioclavicular separation, shoulder dislocation, instability, or tendonitis. While the middle age or older adults are the most common causes are the glenohumeral arthritis, osteoarthritic changes, acromioclavicular arthritis, adhesive capsulitis, and rotator cuff tears. What about the site and character of pain? It is important to determine the exact site of the patient's pain, although shoulder pain is often poorly localized. But when the patient complaining of anterior shoulder pain, you should consider bicipital tendinopathy, acromioclavicular dysfunction, impingement syndrome, instability or subluxation dislocation of the joints, labral tear, clavicular fracture, or glenohumeral joint disease. However, with the lateral shoulder pain, you should consider the rotator cuff strain, tears, deltoid strain. Superior shoulder pain, consider the subacromial bursitis, subdeltoid bursitis, the impingement syndrome, cervical spine disease, and acromioclavicular joint separation. Posterior shoulder pain, consider the rotator cuff, also the cervical spine disease, the radiating pain or referred pain, and the supraclavicular notch, also subscapular notch, cyst in the suprascapular notch presented also with posterior shoulder pain. Here, the character of shoulder pain may be a sharp stabbing pain like this, here in the red color, may be a sharp stabbing pain in the deltoid region, may be a numbness or pain prick or needling like this in the cervical radiculopathy, burning pain like this in the inflamed bursa, subdeltoid bursitis, or subscapular bursitis, maybe dull aching or sharp pain like periarthritis shoulder. All these characters of pain may be presented in our patients. What about the onset and duration of symptoms? As we said before, the acute pain means that the duration of pain less than 6 weeks. The causes of acute pain are fractures, acromioclavicular separation, glenohumeral dislocation, and rotator cuff tear. All are traumatic causes of shoulder pain. But the chronic pain, that the duration of pain here are more than 12 weeks, and this the causes of these chronic pains are mainly glenohumeral arthritis, inflammatory arthritis, acromioclavicular arthritis, adhesive capsulitis, all these causes of chronic pain. The characteristics of pain should be also be learned. The pain with overhead activity means rotator cuff tear. Pain with reaching across the body means acromioclavicular joint. Pain with reaching back means a frozen shoulder, and pain at night means a frozen shoulder, infection, tumors, rotator cuff tears. Sudden onset of intense latent shoulder pain followed by flaccid paralysis means brachial neuritis or shoulder girdle neuritis, or Parsonage-Turner syndrome. This is a very important cause of shoulder pain. Here the patient complaining of severe sudden onset of pain, awaking him from sleep, and 1 week after the pain is improved, and there is an intensive atrophy of the deltoid and biceps muscle. This is the Parsonage-Turner syndrome. Not all the shoulder pain is originating from the shoulder itself, maybe radiating from another side, like the sternoclavicular joint may be radiating to the front of the neck, and the supraclavicular region. The acromioclavicular joint may be radiating to the upper trapezius and the lateral neck. The subacromial space may be radiating to the lateral brachium, and the biceps tendon, if there is a tear or inflammation, may be radiating to the anterior aspect of the arm. The referred pain from another region, like the neck, may be also leading to a shoulder pain, like cervical radiculopathy, pain starting in the neck and radiating lower to the shoulder and the elbow. The acromioclavicular joint inflammation may be radiating to the C4 deformity dermatomes. Also, the glenohumeral joint may be radiating to C5 dermatomes over the deltoid muscle. Other sources of referred pain in the shoulder may come from the heart, like in cases of myocardial ischemia radiating to the right shoulder, and diaphragmatic irritation also radiating to the right shoulder. Liver, gallbladder diseases also may be radiating to the shoulder. The associated symptoms of shoulder pain help you to differentiate the cause of shoulder pain, like neurovascular structures, the arterial ischemia, Raynaud's phenomena, venous congestion, cold intolerance, ulnar nerve paresthesia. All these are a manifestation of thoracic outlet syndrome, which is an entrapment of the lower trunk of brachial plexus and the neurovascular bundle. Also, this is a very important differential diagnosis for the shoulder pain, because the patient comes to you presenting with the pain in the shoulder and radiating to the arm, and associated with ischemia or cold intolerance and paresthesia in the ulnar distribution. And this is a very important differential diagnosis here, the thoracic outlet syndrome. Also, the neurological manifestation, like numbness, tingling, weakness in cases of cervical radiculopathy, like C5 radiculopathy, C6 radiculopathy. The pain starts in the neck and then proceeds to the deltoid region, and then comes to leading to numbness and tingling in the thumb and the index fingers. In this situation, you should ask for a cervical X-ray or MRI to exclude the cervical disc lesion. Constitutional symptoms like fever, anorexia, infection, tumors, all these help you to differentiate the causes of inflammatory shoulder pain in rheumatoid or juvenile idiopathic arthritis and septic arthritis. All these help you in the differential diagnosis of shoulder pain. And thank you for your attention.